Changed the title a little bit, and I said, is more or less better, or more or less? You know, must be some kind of joke there. Okay, these are my disclosures. This is my email. I'll show my email at the end. I know that Manu maybe will circulate the tape talks, but if you want a copy of my slides, send me an email within the next 2 weeks and you get it. So we have a problem. This is a recent user study that shows that the mortality rate for patients undergoing non-cardiac surgery is higher than anticipated, and there's a feeling we need to do something about it. And one of the things that we can do about it is the perioperative goal-directed therapy, which was shown to improve outcome. And we are faced with a lot of data and a lot of meta-analysis that shows that the use of a preemptive strategy of hemodynamic monitoring and coupled therapy reduces surgical mortality and morbidity. And the interesting thing is that even a long-term mortality is being reduced because the number of complications in patients that receive goal-directed therapy is smaller. So the goals can be variable, and there are a lot of goals, but the basic technique of perioperative optimization of goal-directed therapy is to maximize the stroke volume with colloids until the stroke volume doesn't increase anymore. There is another way that is recommended, and that is to choose as goals supranormal values of cardiac index and oxygen delivery. So there are actually two main strategies for this. And as early as 1999, the late David Bennett, that we all so love, said it may be considered unethical not to use goal-directed therapy. Here we have recently in the American literature, we believe that a minimally invasive cardiac output monitor should be considered in all major surgery. And in the UK, where most of the studies and the movement for goal-directed therapy came, NICE recommended the use of esophageal Doppler in all patients with high-risk surgery because it reduces complication, reduces the use of central venous catheter, and in-hospital stay reduces cost. Now, this is a survey that was sent, the main author here is Maxime Canesson, and we sent this to anesthesiologists of the ASA and the ESA, and we asked them what is the monitoring that they apply routinely in the management of these patients, and we see that the answer is that cardiac output is being monitored only in 30% of the cases, and I think that this is a huge overestimation. I think that in reality it is a lot less. And when discussing this paper, the Parker and Boyd said that this questionnaire showed that the practice remains out of sync with the current evidence base. And why is this happening? Is it because physicians still doubt the evidence base, worry about inaccuracy, or just lack motivation? So you can hear a lot of topics recommending goal-directed therapy, but I will try to explain maybe why the penetration of goal-directed therapy is slower than expected. First of all, the mechanism remains uncertain because what is the rationale? The rationale is that major surgery generates a strong systemic inflammatory response and an increase in oxygen demand, and that the patients that do not have the physiological reserve to increase the cardiac output then don't have enough tissue perfusion and therefore have more post-operative complications. And in this animal study, indeed, you can see that in pigs that received goal-directed colloid therapy, that the microcirculatory blood flow and the tissue oxygen was higher in the colon in those pigs, and that may really explain this mechanism. This is Rupert Pierce, who's one of the the people worked most, and he did a study in patients, and he looked at sublingual and cutaneous microvascular flow, and he showed that they are improved with goal-directed therapy when you maximize stroke volume and you add some dopexamine. Unfortunately, in this study, the improvement was not associated with a difference in inflammatory marker or in the complication rate. So this is Henry Caylett. Maybe you know the name, one of the big gurus of perioperative care. He's the surgeon, and he said there is an urgent need to evaluate the pathophysiological mechanism. We don't really understand. The other thing that maybe makes it a little difficult is that the studies that were done with goal-directed therapy were done usually intraoperatively. Some were done post-operatively, some were done preoperatively. So does it always work? Look at this is early goal-directed therapy after major surgery. It's not like the concept of early goal-directed therapy in sepsis. So in perioperatively, it works also after the insult is being done, which makes us a little uncomfortable maybe. The confusion can be reflected in these guidelines, by the way, that were shown before, the gift-of-soup guideline. And the guidelines came because of concern of fluid overload. But look what they have done. They took the recommendation based on the evidence, and according to these guidelines, you have to do goal-directed therapy pre-op, intra-op, and post-op. Certainly, these people will get a lot of fluids, and I'll come to that later. So the evidence is still being questioned. There is some problems maybe with the design of the studies. A lot of the studies are coming from the UK. And I would like just to point out what Rupert Pierce said here, that there are distinct challenges associated with the design and conduct of these studies, that the findings of the first studies, okay, have to be interpreted with caution because of the context of the design, that there is a problem of blinding, especially in the small studies, and there is a lack of confirmation of large trial. And some of the studies are negative, like this one. This is a double-blind prospective randomized study that showed that the heterostarch group had a longer hospital stay, that goal-directed fluid management with colloid solution offers no advantage and is more costly. This is a recent study showing that intraoperative stroke volume optimization conferred no additional benefit, and in young patients who are aerobically fit, goal-directed therapy was associated with a detrimental effect on the primary outcome. And therefore, they say that goal-directed therapy focusing on stroke volume maximization may have important limitations, including the risk of iatrogenic fluid overload. And this is just a study that showed that the addition of dopexamine, which was the original inotrope that was used in these studies, that it does not confer any additional clinical benefit. So the evidence is not so one-sided. Look at this. This is a paper, an editorial that was published in Anesthesia and caused a lot of commotion. When reading the clinical trial relating to the use of esophageal Doppler, it is striking that the prime intervention differentiating control from study group patient is the infusion of 500 ml of colloid. Can it really be that monitoring device used for up to 4 hours out of 8-day hospital stay and the infusion of a small bag of fluid can save the NHS 1,100 pounds a year? And if so, why not just adopt a less conservative approach of intraoperative fluid balance and dispense with a monitoring device as well? So you see, not everybody, even in the UK, is buying that story. Now, what worries me is indeed that goal-directed therapy can lead under some circumstances to detrimental fluid overload. In fact, when we look at the studies, we see that usually the goal-directed therapy group receives more fluid. This is a very famous study from 2005, that they get more fluid. This is a meta-analysis showing that in all these studies, The goal-directed therapy group received more colloids. This is an interesting study. This is Maurizio Ciccone went with Andy Rhodes, and here they did a goal-directed therapy in patients that underwent an elective total hip replacement. And look at the amount of fluid that these patients got. These patients for elective total hip replacement received 6 liters of fluid. Don't you think that that is kind of excessive? And then people say, well, you know what, if they all receive so much fluids, why don't we start giving fluids without monitoring? This is what is called the pragmatic approach, and this is the focus study. And what they did, they just loaded the patients with fluids without monitoring cardiac output. They look at this as also an interesting conclusion. Preoperative intravenous fluid loading leads to a non-significant reduction in hospital lengths of stay after high-risk surgery and is likely to be cost-effective. So you see, there is a permissive approach here to fluid loading. But be careful. IV fluid, the most commonly used drug in the hospital, are a double-edged sword, okay? We know now that maybe we have to reappraise the fluid requirement that we give perioperatively, and there is a lot of people that concentrate on them. Some of them are from this group. They show that blood volume after fasting is normal, and fluid-consuming thirst space has never been reliably shown. We mentioned the glycocalyx and the importance of glycocalyx, and then it can be damaged by hypervolemia, not just by ischemia, and as a result, there is an increase in microvascular permeability, an increase in interstitial edema. Avoiding hypervolemia plays a pivotal role when treating patients both perioperatively and in the ICU. We have the studies that show that restrictive regimen improves outcome and decreases length of stay and improves gut function post-operatively. And the dangers of fluid overload have to be reminded again. Some were already mentioned. This is an older study. Patients who had, I just brought two studies. One is an older one from 1990, patient that had 20% weight gain, had more vasopressor dependent, higher mortality, and that the morbidity of fluid overload can be significant. This is a much more recent paper from critical care medicine showing that fluid overload was a variable most related to the length of stay in the ICU and to mortality. And this is, again, from the UK. Indeed, the pendulum is swinging back. This is the National Confidential Inquiry into Perioperative Deaths in the UK, showing that overhydration is a contributory cause to the genesis of post-operative problem, and that carefully considered case histories have led to specific recommendations regarding fluid restriction, especially in old and fragile. So we have to be careful when we advocate strategies that increase fluid administration. Now, one of the reasons that patients get too much fluid is this protocol, okay? Now, this is the basic CardioQ or esophageal Doppler protocol to give fluid. And what you do is you give fluids. If the cardiac output goes up, you give fluids. So, in fact, what you want to get is you want to get to the flat portion of the left ventricular function curve. It's a little uncomfortable place to be physiologically. But look at the other side, and the red side. When the stroke volume decreases, what do? You give fluids again. So if the stroke volume increases, you give fluid. If the stroke volume decreases, you give fluid. You assume, the assumption here is that any decrease in stroke volume is due to a reduction in preload. But look at this study. This study had to do with plethysmographic variability index, but they showed that a decrease, an intraoperative decrease in stroke volume of more than 10% has a sensitivity of only 37% in detecting fluid responsiveness. So if the cardiac output goes down, it doesn't mean that the patient needs fluid. And if you work with this, what I consider to be oversimplistic protocol or algorithm that is suggested by the esophageal Doppler, you will end up giving too much fluid. And we know that only 50% of the patient in intensive care or perioperatively do respond to fluid. And this is why we have, this is a review that will be very shortly, I hope, published in Critical Care, and it has to do about the use of functional hemodynamic parameter during goal-directed therapy. And our conclusion of this review is the functional hemodynamic parameters offer unique information about fluid responsiveness, have helped detect fluid needs and avoid unnecessary fluid loading, because there are very few goal-directed therapy studies that have examined fluid responsiveness before giving fluids, and this is our recommendation. Now, the last topic I would like to touch upon is, should optimization to supernormal values be done in all patients? These are the classic studies. This is the shoemaker concept. Every patient needs to have a cardiac index of at least 4.5, an oxygen delivery of more than 600 ml per kilo per minute, and this was repeated in the study of Boyd and Bennett. But let's not forget that there are some negative studies out there which showed that resuscitation to supernormal values doesn't help. And this is why in critical care, at least, it went out of vogue quite some years ago. Now it is coming back intraoperatively. This is how it looks, okay? So this is the study I showed you before of Ciccone and his colleagues in patient during elective total hip replacement. What you do is you give colloids until the patient is not responsive anymore, and then you start the butamine to get to this magic number. And this is protocol that is based on this on the St. George Hospital protocol of Rupert Pierce from 2005. And I said already, look how much fluid these patients receive, but look at the heart rate. Look at the heart rate of the patients in the protocol group, the goal-directed therapy that received the butamine. They are much more tachycardic than the other group. But that's against everything we learned in recent years of how to protect patients in the perioperative period. And we know that, at least in cardiac surgery, that patients that receive catecholamines have a higher incidence of both major cardiac morbidity and all-cause intra-hospital mortality. The butamine should be administered when benefit is judged to outweigh the risk, and only then. This is another study in cardiac patient undergoing that inotrope exposure appears to be independently associated with increased hospital mortality and renal dysfunction. So, and this is Rupert Pierce. Again, I admire his responsibility in saying that, because he is behind many of these studies. It seems clear that continued pursuit of hemodynamic goals in patients who do not respond is harmful, that the adverse effect of fluid and inotropic therapy will be most serious to patients with significant heart disease. When you ask these people, do you really all patients get their cardiac index to be more than 0.45? Then you hear some different results. So you have to be careful when you interpret the literature. And this is what I like. This is Kalett again. It is essential that the present individualized goal-directed therapy approach includes optimization within the limits of the individual patient cardiac capacity. And this is not the shoemaker concept, okay? So you have to be careful with that. These are my conclusions.
Thank you.
Thank you. But I have several. The reported benefits of perioperative goal-directed therapy are too important to be disregarded, although some conceptual and practical issues still need to be resolved, An individualized goal-directed therapy approach that includes optimization of cardiac output seems safer than the quest for predefined supranormal values. And certainly goal-directed therapy should not lead to a forgiving attitude toward aggressive and potentially detrimental fluid administration. And I thank you for your attention.